Good morning, everybody. Welcome to the National Collaborating Center for Infectious Diseases and our webinar today. The Public Health Agency of Canada's webinar for healthcare providers, COVID-19 vaccine for pediatric use in Canada. The National Collaborating Center for Infectious Diseases is funded by the Public Health Agency of Canada to provide knowledge and evidence for usable formats for public health planning and policy. NCCID is very pleased to be supporting the agency with knowledge translation during the COVID-19 pandemic response, including these vaccine webinars. I'd like to begin by acknowledging that NCCID is hosted by the University of Manitoba in Winnipeg on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We are committed to speaking truth and to working together for reconciliation. Before we begin, I would just like to mention a couple of housekeeping items. We are running this webinar through Zoom. If you have any technical problems, please email us at nccid@umanitoba.ca. The question and answer session today will focus on today's topic, which is COVID-19 vaccine for pediatric use in Canada. The session will be taking place using the Q&A session will be taking place using the tab on your screen marked QA. You can like other people's questions to push them up in priority. We will try to answer as many questions as possible, but we might not get to them all today. NCCID will also use the chat tab for extra communication to you as the participants, so please keep an eye on that chat tab, but it is not open for comments. The recording of this webinar and the presentation slides will be available shortly after the webinar at nccid.ca. I would like to introduce our moderator today, Dr. Joanne Embry. Dr. Embry is a professor with the Department of Pediatrics and Child Health and the Department of Medical Microbiology and Infectious Diseases at the University of Manitoba. She was the chair of the Department of Medical Microbiology and Infectious Diseases from 2001 to 2013, and she currently co-leads the Department of Pediatrics Faculty Development Committee, which aims to mentor and promote women and visible minorities. During this pandemic, Dr. Embry's expertise has been instrumental in navigating infection control practices at the Children's Hospital in Winnipeg, and she now works with the Pediatric Departmental Advisory Group for COVID vaccines for adolescents and children. She has been named one of the top 100 most powerful women in Canada for 2021. Welcome, Dr. Embry.
Thank you very much. Good day, everybody. And I would first like to thank the National Collaborating Center for Infectious Diseases for their support in hosting today and making this webinar possible. And I would also like to welcome our speakers for today's webinar. First is Dr. Nicole Forbes, who is a senior scientific project coordinator at the National Advisory Committee for Immunization, Secretariat, Public Health Agency of Canada. Secondly is Dr. Anne Pham Huy, who is an assistant professor and pediatric infectious disease training program director at the University of Ottawa. She is a pediatric infectious disease specialist and the physician lead for the Special Immunization Clinic and Primary Immunodeficiency Clinic at the Children's Hospital of Eastern Ontario. She is a member of the National Advisory Committee on Immunization and the chair for Immunize Canada. And finally, last but not least, is Dr. Marina Salvadori, who is a professor at McGill University and a member of the Division of Pediatric Infectious Diseases at the Montreal Children's Hospital. She's very interested in vaccine preventable diseases and has been for a long time, and as well as immunization education and awareness. She has been on various roles on the National Advisory Committee on Immunization from 2004 to 2019. In January 2020, she joined the Public Health Agency of Canada as the clinical lead for COVID-19. These are our speakers, which I've already talked about. And next up is the disclosure slides. And as you can see, there are no disclosures related to this presentation. And the next slide are the objectives. This talk is primarily for children aged 5 to 11 years in Canada, and it is going to describe the COVID-19 pandemic amongst this group of children. It is going to summarize the clinical trial information available on the COVID vaccine authorized for children in this age group. We will also explain the NASI recommendations for these vaccines for this age group. And finally, identify the factors that parents or guardians should consider when deciding on COVID-19 vaccine for the children for whom they care. Next slide up is Dr. Nicole Forbes is going to talk about COVID-19 in the pediatric populations.
Thanks so much, Joanne. I'm really happy to be here today. We can go to the next slide. Okay, so children under 12 currently represent the largest unvaccinated population here in Canada. So unlike previous waves of the COVID-19 pandemic, which occurred prior to reaching high vaccination levels in adolescents and adults, Wave 4 is characterized by a higher weekly incidence rate of COVID cases among children aged 5 to 11, which in the graph shown here is in orange. This rate has surpassed both the younger and older age groups in the past months. However, consistent with general population rates, the case rates in ages 5 to 11 have recently decreased. In terms of seroprevalence estimates, we do have some studies from Quebec and British Columbia, and they're both noting that potentially the case level data that's shown here may be an underestimate of infection in this age group. Okay, next slide. Over the course of the pandemic, many children have been infected with the COVID-19 virus, SARS-CoV-2. And in most cases, children have had no symptoms or have experienced mild COVID-19 disease. However, there are cases where children do develop severe COVID-19, and these are less frequent than in older age groups. The percentage of children that do require hospitalization due to severe illness is very low. So as of November 2021, only 0.2% of cases in children ages 5 to 11 did require hospitalization, with slightly higher frequencies reported for younger age groups. And around 1 in 6 children under 12 that did require hospitalization were admitted to ICU, and very few cases resulted in death. Next slide. Okay, so it's really incredibly fortunate that COVID-19 is a mild illness in children. However, because severe disease is less common, there is less evidence available to understand risk factors for severe illness in children. Any child is vulnerable to SARS-CoV-2 infection, and even children without known risk factors may develop severe forms of COVID-19. Known risk factors associated with a greater than 2-fold increase in mortality from COVID-19 that was shown to be independent of age, so inclusive of other age groups as well as children, do include epilepsy, Down syndrome, obesity, neurological disorders, diabetes, and end-stage kidney disease. Additionally, having over one chronic comorbidity is a known risk factor for severe COVID-19 in pediatric and adolescent populations. Next slide. Okay, so multisystem inflammatory syndrome in children, also known as NACI, is a rare but serious condition that can occur in children and adolescents in the weeks following infection with SARS-CoV-2. The average time since infection is typically 2 to 6 weeks to presentation. Little is known about the risk factors for NACI, with the exception of possibly obesity, as this is a comorbidity that is most typically reported for children that have been diagnosed with NACI. It's also more common in males and in racialized individuals. Moving on to the next slide. Based on international studies, NACI is estimated to affect between 0.5 to 3.1% of pediatric cases. In Canada, we report the median age at onset of NACI at 6 years. And while almost every case of NACI reported to date did require hospitalization, most have reported recovery and no cases have resulted in death to date. Next slide. Although it is important to consider the collateral harms caused by the COVID-19 pandemic on children and their families, Throughout the pandemic, we have seen the disproportionate impact restrictive community-based measures have had on children. Prolonged schooling disruptions, social isolation, and reduced access to academic and extracurricular resources have had a profound impact on both the mental and physical well-being of children and their families, and also further exacerbating social inequities. So at this point, I'm going to pass the mic back over to Joanne to go over our interactive polling question. Thank you.
Oh, Joanne, you're muted.
Sorry, I was muted. Clicked too fast. We'll give you 10, 15 seconds to answer this. True or false? Only children with risk factors develop severe forms of COVID-19. Okay, pretty well everyone got that one. As we know, there's limited evidence in this age group. It can happen to any child without risk factors who can develop severe forms. But the risk factors that we have seen that are increased with a twofold increase in mortality is epilepsy, children with Down syndrome, children who are obese with a BMI greater than 40, children with neurologic disorders, children with diabetes, both type 1 and type 2, and end-stage kidney disease. So I'm going to turn this back to Dr. Forbes.
Thanks, Joanne. Okay, so it's my pleasure now to discuss pediatric COVID vaccines available in Canada for individuals under the age of 12. So if we can go forward 2 slides. Thank you very much. Okay, so Health Canada, the National Advisory Committee on Immunization, as well as the Public Health Agency of Canada have distinct roles on the authorization, guidance, and coordination of vaccines in Canada. So in terms of Health Canada's role, they're the federal regulator of health products, including vaccines, and they review scientific evidence from clinical trials and other information before approving vaccines for use in Canada. So the National Advisory Committee on Immunization, on the other hand, also known as NACI, is an independent volunteer committee of Canadian health experts, and they provide advice to the Public Health Agency of Canada on optimal use of approved vaccines. NACI guidelines help provinces and territories plan their vaccination programs. In terms of the role for the Public Health Agency of Canada, they provide NACI the necessary data and support to inform and publish their guidance. And they support the distribution and the communication of NASI recommendations, and they coordinate the distribution of vaccines, which is very important in times of pandemics such as now. So Health Canada and NACI, in fact, continuously monitor vaccines for safety and efficacy. And I also want to note in terms of NACI guidance that it's not uncommon for NACI to make recommendations that are broader or narrower than the conditions of use that are currently approved by Health Canada. Okay, moving on to the next slide. Okay, so in terms of pediatric COVID-19 vaccines that are currently authorized in Canada, we have the Pfizer-BioNTech Comirnaty vaccine, which is the 10 microgram dose. And as of November 19th, 2021, it was authorized by Health Canada for use in children ages 5 to 11. And so this is for 2 doses, 10 micrograms each. And 10 micrograms is 1/3 the adult or adolescent formulation of the Pfizer-BioNTech vaccine, which is 30 micrograms in that age group of 12 and older. So in terms of NACI guidance, they are recommending a minimum 8-week interval between dose 1 and dose 2. And this does differ from Health Canada, which has the authorized interval of 21 days. And I do want to note that this is a new formulation. We do have tromethamine, which is also known as TRIS. So tromethamine or TRIS sucrose is a new buffer in the pediatric formulation. And it's been used for many years in some routine childhood vaccines, as well as other injectable medications without safety concerns. So allergies to tromethamine have been reported, but are extremely rare. And its use is to support pH stability and longer storage under refrigeration, which now includes up to a 10-week storage duration at refrigeration temperatures. In terms of vaccination coverage, I can provide some updates for the uptake of this vaccine. So as of December 10th, 17.5% of children aged 5 to 11 years of age in Canada have received at least one dose of their COVID-19 vaccine. And similarly in the United States, they're reporting 19% of children in the same age group having received at least one dose of the vaccine as of the 12th of December. Okay, moving on to the next slide. So this is a very busy slide. It's more of a reference slide for healthcare professionals to refer to compare the adult adolescent formulation of the Pfizer vaccine, which is shown on the left with the purple cap, to the pediatric formulation, which is shown on the right with the orange cap. So there's a lot of information in this slide. I do want to note that aside from differences in dosage, which is the 30 microgram for adult or adolescent, going down to 10 in pediatric. There are also some differences in storage requirements, allowing for greater time under refrigeration, as I already noted, as well as at room temperature than the adolescent adult formulation. And also noting again, the potential allergens do differ. While both include PEG, only the pediatric formulation includes tromethamine. So I want to also acknowledge that the product monograph will have a fulsome set of information to help healthcare professionals with all the information they need to understand the differences between the two different formulations and the operations that are appropriate for both. Next slide. So in terms of other pediatric COVID-19 vaccines in the distance, not too far distance, we do have the Pfizer-BioNTech vaccine under clinical evaluation currently. And this is for children aged 6 months to 4 years. And so their trials are underway. And like we are seeing with the product for children 5 to 11, they are looking at a lower dose, a 3 microgram dose. And we don't have any information to date on the formulation of this dose, but we are anticipating to receive that information once the product is closer to regulatory review. Pfizer did publicly announce that they could have data on how well its vaccine works in children under the age of 5 by the end of the year. Noting that they are conducting a cohort in children 6 months to 2 years of age, and then another cohort in children 2 to 5 years of age. In terms of the Moderna product, Moderna is currently authorized in Canada for individuals aged 12 and older. And in terms of pediatric formulations, they are looking at a formulation for children aged 6 to 11, and this is currently under regulatory review at Health Canada. They are planning to use the same formulation as the current 12 and older product in Canada that's currently authorized. However, the dose would be lower. So currently it's a 100 microgram dose for those 12 and older, and they're looking at a 50 microgram dose with a volume cut in half to 0.25 mils per dose compared to the 12 and up formulation. In terms of the Moderna product for children aged 6 months to 5 years of age, it is still in clinical review. It's still in clinical trials, and the dose and the formulation are yet to be determined. Okay, so moving on to the next slide. We'll be getting into the clinical trial data that supported the authorization of the Pfizer-BioNTech product for pediatric use in Canada now. First off, I'm going to be talking a little bit about the vaccine trial itself that Pfizer led. So trying not to overcomplicate things, but there were 2 different cohorts in this trial. And it's important to understand this because of the limitations of some of the evidence residing in only cohort 1. So you'll be seeing some numbers in the future, and you'll be able to understand why potentially the numbers are a little bit lower than the total trial numbers. So This trial was a phase 1-2-3 randomized placebo-controlled trial, and its aim was to evaluate the safety, the tolerability, and the immunogenicity of this vaccine at a lower dose, 2 doses 21 days apart. And it was designed to leverage immunogenicity data as a surrogate to efficacy. And so this type of a trial is called an immunobridging trial design, where immune responses to the vaccine were compared to an older population with known efficacy conferred by the vaccine. So with the first cohort, we have 1,518 that received the vaccine and 750 for placebo, and they were followed up to 3.3 months from dose 2. And so this cohort, they evaluated the safety, the immunogenicity, and the efficacy outcomes that we'll be discussing. And then there was a subsequent safety cohort that was added onto the trial, randomizing an additional 1,591 to vaccine and 788 participants to placebo. And again, this is all for children 5 to 11. And this was limited to a 2.4-week follow-up from dose 2 and was only used to look at the interim safety data that was evaluated. Okay, so moving on to the next slide. Okay, so looking at the safety of the vaccine for children 5 to 11 years of age, reactions to the vaccine were mostly mild to moderate and short-lived. Compared to children 16 to 25 years of age that received a 30 microgram dose, children aged 5 to 11 did report slightly more local reactions, specifically swelling and redness at the vaccine site, and slightly less systemic reactions, including fever. There were no cases of myocarditis or pericarditis or death or MIS-C, anaphylaxis, or anaphylactoid reactions that were reported in this trial. However, it is important to note that the frequency of rare adverse events that occurred at a frequency of 1 in 1,000 or less frequent would be unable to be reported due to the trial size. And we have detailed frequencies of safety outcomes provided in our supplementary slides that are available to participants of the webinar, as well as the general public. Okay, going on to the next slide. In terms of the immune response to the Pfizer vaccine, the immune response was assessed following the second dose of the vaccine for cohort 1, and they were looking at the antibody levels, which is the geometric mean titer, or GMT, as well as the percentage of individuals that mounted an antibody response. So that's called seroprevalence. And they found that these responses were similar in children aged 5 to 11 that received the 10 microgram vaccine compared to individuals aged 16 to 25 that received the 30 microgram vaccine. And so when they looked at the comparison, they were able to basically leverage that to predetermined immunobridging criteria. And they were able to say that they were able to establish a non-inferior status of this vaccine in this age group. And so additional analyses indicated that antibody-mediated virus neutralization was similar following vaccination for both the wild type as well as the Delta variant. However, this data is not included in this deck. We do provide a resource if you would like to look at additional information for these immunogenicity outcomes, though. Okay, moving on to the next slide. Okay, so this is looking at the interim phase 2-3 findings in children 5 to 11. And what we're seeing here is efficacy following dose 1. And this is against symptomatic COVID-19. So they weren't looking at individuals that were not presenting with symptoms. They were looking at individuals that were identified due to symptomatic COVID-19. And they saw that there was a similar estimate of vaccine efficacy against this outcome and to those observed in individuals aged 12 and older. So it was estimated at 90.7% efficacy against symptomatic COVID-19 following dose 2. I do want to note, however, that there were very few cases that were reported. So there were 3 cases that occurred of symptomatic COVID-19 in the placebo group, in the vaccine group, and only 16 in the placebo group. And there were no severe outcomes in either group for placebo or vaccine administered participants. And so it did limit their efficacy analysis, but you can see here, this is following dose 2, and you can see when the events occurred over time. So I'll be passing the mic back over to Joanne for some more polling questions. Thank you very much.
Okay, the next question. In the clinical trials, 5 to 11-year-olds reported slightly more redness and swelling than 16 to 25-year-olds. Again, 10, 15 seconds to answer. Okay, so most people picked that to be true. And in fact, children did present with more local reactions than did the older adolescents. They did have slightly less systemic reactions, including fever. Most were mild to moderate and short-lived. And as I'm sure everybody in the audience is aware, mild and moderate depends on the person who is experiencing the side effects or the effects of the vaccine. We will continue on with Dr. Forbes.
I'll actually ask Anne to present the next session on behalf of NACI. Thank you.
Sorry, my mistake.
Thanks, Dr. Embry and Dr. Forbes. So I'm delighted to present to you and walk you through the NASI's recommendation on the use of the Pfizer-BioNTech COVID-19 vaccine in children 5 to 11 years of age. And as was mentioned on the National Advisory Committee on Immunization, we make recommendations based on a multitude of different sources and evidence and information beyond the clinical trials as well. Next slide. So the ethical considerations on the use of COVID-19 vaccine in the pediatric population has been reviewed extensively with consultation with the Public Health Ethics Consultative Group. And there's been a few meetings ever since spring of 2021 when we had vaccines authorized in the adolescent pediatric group. The founding guiding principle is that whether vaccination is in the children's best interest. And I think as healthcare provider, we would agree that that is a good guiding principle. So we look at direct benefits for children, which is definitely an important consideration. And generally a vaccination program is justified if its anticipated benefits outweigh its potential risks. But sometimes there's more than just direct benefits as well. And in this case, indirect, which means potentially population level benefits of vaccination, can also benefit children. At this point in time, as we've just seen, the overall safety and effectiveness data for the Pfizer-BioNTech COVID-19 vaccine are limited in children. The precautionary principle justifies taking action under conditions of scientific uncertainty to mitigate vaccine-related risks, including considering data from other age groups and applying vaccination principles. Like I will be saying, in the case of the vaccines in 5 to 11, we're not starting from square one. There's been lots of work and lots of experience in the adolescent adult group, but the precautionary principle still stands. This next statement, I'd like people to really, take a moment to really reflect on. I think it's an important sentence, so I will read it to you, and then we'll talk about it again in future slides. But in this current context, I think that children and their parents or guardians should be supported. They should be respected in their decisions regarding COVID-19 vaccination for the child, whatever decisions they make, and should not be stigmatized for accepting or not accepting the vaccination offer. And as healthcare providers, I think we all have a role in terms of being able to have these open-minded discussions with family and caregivers. For some, this is an easy decision to make for their child. For others, it's a bit more complex, and it's important to be able to, sit down and openly discuss these direct and indirect benefits specific to that child. Next slide. So this is the first recommendation. NACI recommends that a complete series with the Pfizer-BioNTech COVID-19 vaccine of 10 micrograms of the pediatric formulation be offered to children 5 to 11 years of age who do not have a contraindication to the vaccine, with a dosing interval of at least 8 weeks between first and second dose. And this is a discretionary NACI recommendation. NACI will continue to closely review emerging evidence in real time on a very frequent basis and will update the recommendation as well as its strength as the evidence base evolves. These recommendations are mainly based on the clinical trial that Dr. Forbes has presented, but on other extrapolated also from vaccine principles and other sources. Next slide. We want to update a little bit more or give further clarification on NACI's considerations on the recommended interval between dose 1 and 2. So at this point in time, the recommendation is to have at least 8 weeks between the first and second dose of the vaccine. The clinical trial, as well as the Health Canada authorization, is a primary series of 2 doses given 21 days apart. So this is a very common question. Why the 8 weeks? What was the basis of the rationale for this extended interval? So 2 reasons. Reason number 1 is that we have increasing emerging evidence from our adolescent and adult population that suggests that a longer interval between the first and second doses of a primary series results in a stronger immune response and higher vaccine effectiveness that is expected to last longer compared to shorter intervals. As we all know, in the early rollout of the COVID-19 vaccines in our adult populations, there was some vaccine supply. And so at that point in time, many Canadians and many other individuals across the world received the vaccine in an extended interval up to, for example, 16 weeks. And now we have data on the outcome or the immune responses to those of that practice. Essentially, longer interval, more durable, more robust response, which leads to improved in effectiveness. Second reason that has been reviewed is that the extended interval may also be associated with a reduced risk of myocarditis and pericarditis following a second dose of an mRNA COVID-19 vaccine. So as you may be well aware, there have been rare reports of myocarditis and pericarditis following mRNA COVID-19 vaccines. And observation and study of those reports seem to suggest that with the longer interval, there are decreased rates of this adverse event. So again, 2 reasons for doing the extended interval. One is improved immune response and likely effectiveness, and number 2 is safety. Next slide. Here I'll present to you what is the NACI guidance for children with previous SARS-CoV-2 infection or MIS-C. Again, MIS-C is the multi-inflammatory syndrome seen in children. So the recommendation is that if you've been previously infected or you've had previous MIS-C, that 2 doses of a COVID-19 vaccine may be offered to children 5 to 11. The caveat is that obviously children should no longer be considered infectious based on their current criteria, and the symptoms of their acute illness should be completely resolved prior to vaccination. So we do not give a timing from the infection, but definitely has to be completely resolved. For the case of children with a previous history of MIS-C, vaccination should be postponed until complete clinical recovery has been achieved or until it has been more than 90 days since diagnosis, whichever is longer. Next slide. Especially in pediatrics, this is an important one and logistically one that we got clarification for in practice. So what is the NACI guidance on the concomitant administration of other vaccines? So the current recommendation is that COVID-19 vaccines for children 5 to 11 should not routinely be given concomitantly, i.e. the same day, with other vaccines, live or non-live. And I think one of the keywords is routinely be given. So through post-market safety surveillance, we will be, in the coming weeks, and as we are closely monitoring this, we will be better at estimating any adverse events or the risk of adverse events that may occur in this population. But we're still in the early rollout of pediatric COVID-19 vaccines. And as a precaution, we are recommending to not routinely provide different vaccines at the same time in order to be able to distinguish an adverse event that's associated with either the COVID-19 vaccine or another vaccine. So again, this is the early stage rollout. This is a precaution. This is not a contraindication, because in certain situations and for logistical or feasibility considerations, concomitant administration or a shortened interval between COVID-19 vaccines and other vaccines may be warranted on an individual basis. And in those circumstances, we request the clinical discretion of the healthcare provider. So as a precaution, again, NACI suggests waiting 14 days between the COVID-19 vaccine and other vaccines in those 5 to 11 years to reduce reporting errors for adverse events. And I'll remind the audience again that this was an initial recommendation for the adolescent vaccines as well. And as more information, more safety data, and clarification of adverse events was available, this recommendation was updated. And for the adolescent and adults, COVID-19 vaccines can be given concomitantly with other vaccines. But again, for the pediatric 5 to 11, the recommendation is just not to routinely give them together. Next slide. So for all those caregivers of 11, 12 tweens, so this is the guidance on children that are aged 11 who turn 12 during their vaccine series. So there is a bit of a cohort of that is applicable. So in a nutshell, essentially you should be providing the vaccine according to age, whatever that age in real time is. So for children who receive the 10 microgram Pfizer-BioNTech COVID-19 vaccine for their first dose, and then magically turn 12 by the time they're due for their second dose, they should receive the 30 microgram Pfizer-BioNTech COVID-19 vaccine, again, authorized for age 12 years and older to complete their primary series. So that's a recommendation. We do acknowledge that if a second dose of 10 microgram is given, the dose should still be considered valid and the series complete. Next slide. So I'd like to spend a few minutes just talking about some special considerations. So like I mentioned, cases of myocarditis and pericarditis have been reported following an mRNA COVID-19 vaccine. These reports have been rare, but the signal is present. And again, as a precautionary measure and consistent with current recommendations for adolescents and adults, the second dose in the mRNA COVID-19 vaccine series should be deferred in children who experience myocarditis or pericarditis following their first dose of the vaccine series until more information is available. So again, these are kids that present with symptoms that are consistent with what has been reported as the cardiac adverse events following mRNA vaccine. And we recommend to be cautious and defer a second dose. For children who've had, I'm sure the cardiologists get this question a lot, children who've had a history of myocarditis that is unrelated to mRNA COVID-19 vaccine, at this point, we suggest to consult with our clinical team for an individual consideration and recommendation. In general, if they're no longer followed by cardiology or a medical team for their cardiac issue, and that has been completely resolved, they should be able to receive the vaccine safely. Obviously, NACI and other jurisdictions are continuing to monitor the evidence, and we will update these recommendations as needed. As part of the informed consent process, caregivers are advised to seek medical attention for children if they develop symptoms including chest pain, shortness of breath, or palpitations following receipt of the Pfizer-BioNTech vaccine. Next slide. Additional consideration is the pediatric COVID-19 vaccine program planning. Whenever we review these recommendations or the evidence, we do have try to keep an equity lens. So emphasis on equitable access to vaccination information and services to minimize inequities in vaccine acceptance and uptake based on socioeconomic status. Children aged 5 to 11 years and their parents should be supported and respected in their decisions regarding COVID-19 vaccinations for their children, whatever decisions they make and are not stigmatized for accepting or not accepting the vaccination offer. So hopefully those who listen, you will note that this is the second time I say that sentence, because it is a very important concept in this rollout of pediatric vaccine and how we approach vaccine decision-making and counseling. Adults, including caregivers and youth who interact with children, should be vaccinated to ensure this additional level of protection for themselves and to offer additional protection to children. Beyond vaccination, public health measures continue to be very important in preventing transmission in children. It is important that everyone, regardless of vaccination status, continue to follow recommended public health measures. I will not name the new variant in town, but I mean, there's multiple other reasons as well. The Pfizer-BioNTech COVID-19 vaccine is not authorized for use in children under 5 years of age at this time. But as you heard from Dr. Forbes, there are clinical trials undergoing that are ongoing to look at vaccines for the 6 months to under 5 years of age. Next slide. Ooh, this is the exciting interactive polling part of my part. Just make sure you guys listen. So I'll let Dr. Embry lead this.
I get to ask this one. So we'll give you about 10-15 seconds to go through this, but what does NACI recommend for children who receive 10 micrograms of the vaccine for their first dose and then turn 12 before they get their second? Okay, yes, you can either give the larger dose that you would give to an older child, or you can give the 10 microgram dose for the second shot, but both would be considered to be complete. So you have a choice there. Thank you very much for your session. And these are the key takeaway. You can see the full guidance for the NASI recommendations. And
People
then
should
we
bookmark that
Yes.
on your computer and just read it. It's a lovely read.
Perfect. Yes. Thank you again. And we'll move on to Dr. Salvadori.
Okay. So I'm just going to very briefly talk about different ways to talk to parents and how to support parental decision making. So as you know, this is a very difficult decision for some families. Healthcare providers should engage the parents and guardians in a respectful and culturally safe way about vaccines for children and discuss the risks and benefits of vaccination for their family. There is evidence that talking about broader societal benefits and some of the messaging around, good citizens get vaccinated is actually detrimental to this conversation. And for people who are not quite sure, in fact, it makes them more polarized and less likely to get vaccinated. So for this particular group, parents really see it as a very important family and personal decision. And so you should frame your risk-benefit discussion with the family around that family and that child. Every family will be in a different situation, and the direct and indirect benefits for that family will be specific and different for that family. It depends on their social, economic, value-based factors, how many people are living in the home, where they work, if there's people with vulnerabilities, et cetera, within their home. So you really have to tailor it specifically to that family and support them in their decision-making. Conversations may need to take place over several visits. Families should not be rushed. It's really important to say, when they have concerns and questions, answer truthfully. And then if they still are not sure, or even if they've chosen not to get vaccinated, do you leave the door open and say, please come back in 4 to 6 weeks? Because actually the data and the evidence is accumulating extraordinarily quickly, and there may be more changes in the environment, in the data space, and we'll know more in 4 to 6 weeks. So keep encouraging them to come back and continue the conversation. And authorization, in this age group was generally based on benefits outweighing the risks for the child, not for the societal impact per se. Next slide. So different ways to talk about this with the family. So what are the risks? First, we know that they can get mild to moderate side effects, sore arm, etc. Most families, that's not a huge factor. And then there's the unknown risk of other side effects because it's quite new data. And right now, we don't know if there's any unknown side effect that occurs less often than 1 per 1,000 doses. But as we've stated, this is rolled out now across Canada, the United States, and many other countries, and millions of children are getting vaccinated. So that data will be coming in very quickly. The benefits for that child, they are expected protection against symptomatic infection and expected less disruption to school or social engagements. So other considerations are, it's expected that most children in the next year will be exposed to COVID-19. Vaccination may offer parents a sense of security. They may be more comfortable letting their children engage in social and extracurricular activities once they've been vaccinated, and there may be less social isolation for that child. Any underlying health conditions in the child are important to consider, and the parents will factor heavily in their decision-making. The local epidemiology and exposure risk at any given time is really, really important. I think since Black Friday, when we first heard about the Omicron, one can really see how quickly the local epidemiology can change in any given space. So people's decision-making and risk benefit may change, and you have to constantly recalibrate depending on the risk at the time. People have different personal and cultural experiences, both with medical institutions, healthcare institutions, and with vaccines. And I want to point out here that there, time and time again, way before COVID happened, it's well known that the biggest factor in a family vaccinating their child is the recommendation and the thoughtful discussion with their beloved healthcare provider. You're the one that they trust and that they care about, and they want to know your opinion. So even if you're not the one administering the vaccine, they want to take the time to talk to you, and because they trust you. By far, that influences decision-making the most. People are also worried about pain and anxiety for the child, and we have lots of resources in Canada and on our website. There's the card system. There's all kinds of ways to help deal with pain and anxiety with vaccines, and a lot of our COVID vaccine providers and places where they're doing it are really well versed in this. And also probably one of the biggest factors for families is the risk of exposing more vulnerable people in their family and in their community, particularly grandparents and medically fragile or medically ill. Need to be discussed in their risk benefit discussion with each family. Next slide. So overall, the sort of key messages that authorization was based on benefits outweighing the risks for the child themselves. COVID has disproportionately affected children 5 to 11 years of age during the 4th wave. We're hoping, and our main goal is reduce disruptions to their education and in-person activities that are so important for mental and physical health and development of children. And NACI currently recommends that a complete series of the Pfizer COVID-19 vaccine at the 10 microgram dose may be offered to children 5 to 11 years of age who do not have contraindications, with the dosing interval of at least 8 weeks between the doses. And we would, and I would strongly encourage you to sort of try and frame the discussions with family in the frame of individual risk benefit decisions for that family. And I think it's really important not to polarize these discussions. There's been so much polarization of so much medical information, and let's meet each family where they're at, and then leave the door open and discuss these again as evidence and data and knowledge accrues in real time. So I think we're at our question and answer session now.
Yeah, I popped up.
Mhm.
Thank you very much. And I'd like to thank all our speakers, just in case we run out of time before I get a chance to do that again. There were questions that were submitted prior to the webinar, and I think we can relatively quickly go through those, as some of them may have been answered by the speakers. And the first one is for Dr. Salvadori. Any more information on why the Pfizer vaccine for children 5 to 11 years uses a smaller dose than that for adults and adolescents? Is there any other information that wasn't presented at this webinar?
So as in this whole vaccine development space, obviously the timelines were compressed and all the companies had to make best, they did like small trials in small groups of children, adults, and elderly to see the vaccine responses, but there's a lot that wasn't known and still isn't known. Like we don't know the exact correlative protection, but we do now know that a group antibody level correlates with certain protection against the vaccine. So different doses, just small numbers of doses and small numbers of children were trialed, and the 10 microgram dose seemed to work well. And so they expanded and did the randomized control trial with that dose. And as you saw, what we call the immunobridging, it had the same antibody response in children 5 to 11 as in adolescents and young adults 16 to 25. Just so you know, there's actually Pfizer is going to do a 10 microgram study in adolescents now, because as we learn, we don't know the exact right dose. And, but we know that this dose had the same antibody levels and certainly seems to have at least a 90% efficacy against symptomatic infection. And we anticipate it will have the same characteristics of protection, et cetera, as those who got older people who got the different doses.
Okay, thank you. Dr. Fimwe, another question again, which may have been answered, is why does NASI recommendation for children's 5 to 12 indicate the vaccine may be offered instead of should be offered? What's the difference in the wording?
Yeah, words are important. So NASI is a technical advisory group and we give technical advice to the Public Health Agency of Canada. And we have two types of recommendation, or two broad types of recommendation. One is a strong recommendation, and often you'll see when we use a strong recommendation, the wording will be like, X vaccine should be used or should not be used. That usually is a statement that really applies to the broader population. Most people, that recommendation would hold true. The other type of recommendation we give is the discretionary recommendation, where there may be other nuances. There may be, in an era where there's increasing information, early rollout, where it may be offered, which again is beneficial, or the benefits outweigh the risk for the many people, but there are other consideration at play, and often with increasing evidence or more post-marketing surveillance, that recommendation may change and be updated. So those are just a little bit the clarification. I hope that answers that question.
Thank you. Back to Dr. Salvadori. And
can but before you ask, I want to take on the specific people who are asking about the Covaxin, because I don't want people to think that we're ignoring Covaxin and other vaccines. So right now there's a large vaccine landscape, and the Pfizer 10 microgram vaccine is the only one that's gone through our regulatory process and that has been authorized. As the other vaccines come on, they will be looked at carefully by First Health Canada and NACI, and recommendations will be made. Someone in the chat asked, saying that people want a more traditional vaccine, more traditional as in the protein subunit, or perhaps like a whole cell killed viral vaccine. And those are being used in different places around the world. The first protein subunit vaccine that will be available in Canada is very likely to be Novavax, and we expect that early in the new year. It won't be authorized yet for children because we have to look at the data. But I just want to say that these are not choices that are made at a national level to exclude or include some of the vaccines. It's how fast the companies make the data, submit it for authorization, and then it goes through the regulatory process. So stay tuned, and we'll see as we see more data on those vaccines.
Okay, I'll cross that next question off my list. Going back though, how does Omicron affect vaccine efficacy? Sorry about that.
Yeah, so Omicron. So, as I said, it arrived on Black Friday, so aptly named. We're learning at rapid speed. And the three most important questions for a new variant like this are, is it more transmissible? What's the severity of the disease? And is there vaccine escape, or how much vaccine escape? So it's at this point, and it's really, let's be honest, been only a few weeks, we know it's more transmissible. It is definitely more transmissible. And there is some vaccine escape. So I think that you have to look at, and severity, we really don't know yet, because when these first start, it's hard to get all the clinical information. And often it's younger people who are infected first, who often don't have as commonly severe outcomes. So I don't know yet about severity, but the other two we're starting to get quite a good picture of. So I think there's a few important concepts here I want to bring together. The first, and this is a general vaccine principle, the farther apart the doses of a vaccine are, the higher your immune response, the better your immune response, and the broader it is, the better what we call things like affinity, the better it is at working against the virus. So the 8 weeks apart between dose 1 and dose 2, originally when that was done in Canada, it wasn't just done because there was not enough vaccine. It was done in a thoughtful way that it was very, very likely to benefit everyone who got a dose interval that was at least 8 weeks. We know this from other vaccines, and that has borne out to be true. And so the 0 to 8 weeks, in my view, and I know there will be people with different views, I think it's important. And in a child, especially a child 5 to 11, who at this moment doesn't seem at, not really, really high risk of an adverse event, or an adverse outcome if they caught COVID-19, they have some risk. I'd rather they developed a strong, robust response. And why does that matter? We know that with Omicron, it looks like the higher the titer, you actually have the higher the titer and the better your immune response, you definitely have some protection against Omicron. It's not going to last forever, but we know that, those with low titers, that goes down more quickly, and the higher the titer takes longer to go down. So the best immune responses protect you against these variants so far for a little bit longer and a little bit better. So, we definitely have some protection, but it's unlikely to be absolutely complete. And we have to wait and see what happens, but it is likely that we may need some specific Omicron boosters in the future. But to be fair, it's a brand new virus and we're looking at it really carefully. I just like to use it to, again, go to talk about those principles, that the time between vaccines gives you a far better response. So you're trying to balance your risk while you're waiting to get a better response with getting a long-term, better, more robust response that will serve you. So I say to people when they ask me, should I reduce the incidence because of Omicron and Christmas? I say to them, vaccines alone are not going to get us out of this Omicron problem. They're one tool in the toolbox. They're one very important layer of protection. So if you think you can get 2 doses 3 weeks apart and then have a wild Christmas, that's not true. You really still should be carefully, small groups, well-ventilated spaces, and with people who you don't see very often, wear masks. And I more see it as a lens that I'm not looking at Christmas. I look with the lens of March break. And for kids, I really want them to get the best, most robust immune response that they can get. Though I recognize that there's people with different views and we're learning as we go.
I think those are great. If I can just follow up on that, because I know it's a lot of concerns for families, especially with the holidays coming up and then increasing rates in many communities and what to do. And they want to have a second dose maybe before school restarts. So all of these considerations are important. I think all the principles that Dr. Salvadori said, it holds true. And it's always good to go back to principles. But like this pandemic has taught us, it's important to keep, things change very quickly. And that you cannot, we cannot use vaccines as our sole. It's not bulletproof. It's not a full bubble shield, but it is a good tool. So same thing, same principles. We'll just have to wait and see how things go. But if you're able to weight those, knowing the principles, definitely durable, robust, and long-term protection is in the long term what's needed.
Okay, thank you. I'm taking a look at housekeeping, and I think we have time for just one more question. And Dr. Salvadori, how does natural immunity count in all of the calculations regarding needing the immunizations and the boosters?
Yeah, so that's a really good question. NACI has looked at that. And, as we continue to gain evidence, certainly having had a natural infection does contribute to your immune response. It makes your immune response stronger, and it does make your immune response broader. And at this point in time, and again, this will change as we go through time, NACI has looked at it quite recently and has said that despite natural infection, at the current recommendation is 2 doses of the vaccine, like continuing along with the vaccine schedule. There are some provinces and some other countries that count the natural infection as 1 dose. Basically, it replaces 1 dose of the vaccine. I don't quibble on that. I think there's evidence either way. And this is something to say, we're not 100% sure. There's no definitive right answer. Either way works for me. But it seems very clear right now in the evidence that having some vaccine and some natural immunity, though I wouldn't be going out to try and find natural immunity, but actually does help your immune response.
Okay. Dr. Salvadori, the questions are for you.
Oh, yay.
Yeah. How much information is there about NACI for Canadian cases?
That is part of our Canadian surveillance, getting NACI. NACI is a bit hard because there's not a lab test that you can do, and it's what we call a syndrome. So you have to sort of look and see if it fits in with the criteria. But it is we do collect the data. I don't actually have at the tip of my fingers the most recent, but if you look on the Canada.ca website, you can see it in our surveillance figures. And we are collecting it in Canada. I'm not really sure any other information I can give. We know who's hospitalized. We know their ages and how long they're in hospital and some outcomes.
Okay. And moving on as well for you. Why is tromethamine used as a component of the pediatric vaccine?
Yeah, so the reason that Pfizer added the tromethamine was just to improve how long you could use the vaccine for. So it actually expands. Now, I always get the words technically wrong. I don't know if it's shelf life or life once it's already punctured, but one of those two. Nicole is not here anymore. She knows this better. So it just expands the length of time that you can have a thawed vaccine that's reconstituted and continue to use it. So it just makes it better, especially in pediatrics where there may be smaller numbers of children in specific clinics, pharmacies, et cetera, to use it. And just for interest, that it was actually already in the Moderna vaccines. So this is not a brand new component, which we don't have experience with.
Okay. Another question is, what's the risk of myocarditis and pericarditis in adults versus children?
Yeah. So myocarditis and the pericarditis, again, at first, it's a clinical diagnosis. People have to come for care, and some have lab tests and some do not. But what we can generally say is it's more common in males and female, but really only 60-65% are males and the rest are females. It's far more common in the 12 to under 30 age group with the vaccine. And for those over 30, it still does exist, but it's much, much, much less common. And we still don't know yet in the children who are in the 5 to 11 age group. So far in Canada, but it did just start, we have not received reports of it, but the US did a much larger group. And remember that most of the myocarditis is being seen after second dose. So very few Canadian children have had a second dose. The US has just started giving the second dose to children in the last 10 or 12 days. And we will definitely be looking closely and expect to get some reports of it from them.
Okay. Dr. Famui, coming back to you. Do you think we're going to be giving a booster dose to children age 5 and 11 ultimately?
That's a good crystal ball question, extrapolating. So we don't know. But based on, adolescent and adult, we'll have to see if we're still in this pandemic and, in the future. And then again, what happens. But, what we've seen and what Marina alluded to is that, if you have high titers, durable, that's good for protection as antibodies decline, which they always decline. That's what they do. And if there's still high rates of community spread of the whatever variant of the day is, there may be a need and a place for providing additional doses of vaccine to kind of increase that titer. But again, we're recommending right from the start of a longer duration. So we're hoping to get higher titers that decline over time in a slower fashion. So we'll see. We are following that very closely.
Okay, last question, and I'm going to get you both to answer it, but I'll start off with Dr. Famui. What would you say is the main take-home data to discuss with parents that emphasizes that the vaccine has been approved based on the benefit to the child? And specifically as well, what do you believe is the best response to give to parents about potential long-term effects of the vaccine? There's a lot in the social media about that.
Yeah, so at the end of the day, it's a risk benefit, and however you look at in general, I think it's not to how do you say, inflate or to inflate the risk of adverse events. They are there, they are real. It does happen, but to also think of the risk of COVID infection in child, both of interruptions of direct severity of disease or symptomatic disease, all the impact of what happens if your child gets COVID-19 infection currently. And so at the end of the day, and I've done this discussion many times, the benefits do outweigh the risk, but I do acknowledge that there are some unknowns that remain. Unknowns doesn't necessarily mean unsafe as well. So that's kind of the gestalt, if you will. And sorry, the second question you.
The second is potential long-term.
Oh, the long-term. Oh, I love this question. So I am, so this is based on what we know about all the other vaccines. And so adverse events following nasation typically occur fairly shortly after a vaccine, generally a few days, but, after a couple of weeks. So it's not expected or not reported to have effects that is going to occur 10 years down the road. So if the long term is like we're talking decades down the road, I from a vaccinology perspective, from an immune system or immunology perspective, that is not a big concern. Even with I've heard like mRNA, we don't know, but we know what mRNA is, right? And so so for the long term, decades down the road, I'm not concerned. I am watching very closely the short-term effects or even the rare ones, right? Like, so within a few days to a few weeks, I'd say up to 6 to 8 weeks after the vaccine is provided. So those are some things that I'm watching for, but less concerned with the decade long-term effects.
Dr. Salvadori,
Yeah, this is
answers you.
Thanks. This is actually like the crux of the matter for most families, right? And for most healthcare providers. So I am bluntly honest. I say to them, like, this all is new and there's a lot we don't know. And I'll be honest with you with the things that I do know. So what I don't know is the long-term effects of actually getting this virus in the very long run. We have a pretty good handle now on what happens when you get it, especially when you're a child in the first, 3, 4, 5, 6 weeks, and then a small number get NACI, but I have no idea the long-term effects of the virus. I also acknowledge to them, I'm honest with them, mRNA is a brand new technology. It's actually not the same as all vaccines. And we have this huge cohort, like billions of people now in the world who have gotten it, but it is short term. It is about a year now. So a year is quite a long time. And I reassure them that we have found safety signals, adverse effects with all the different vaccines. I talk about, genuinely, honestly, the serious adverse event of the vaccine-induced thrombotic thrombocytopenia we found with AstraZeneca. We found myocarditis. There's been Bell's palsy. There have been things that have been picked up. And so I don't know if we will find something very, very rare down the line. I think it's highly unlikely, but it is possible. It is also possible that you can find something rare, unusual, and very detrimental having gotten sick. When they directly ask me, about how good is the protection, there are a lot of people want to know natural infection versus vaccine-induced protection. I say we don't have enough information and I can't answer that. And I just talked to them about the risk benefit for their child. And then I say, come back in 6 weeks and we'll talk again, because things really change. And I think that the way I would have discussed it with a parent, in July, when they were off for the summer and everybody was outside and their kids' main interest was playing soccer outside, is different than when they're about to go to school and be in a closed classroom in September. And is probably very different from how I would view the risk benefit now that Omicron seems so transmissible. And it's winter in Canada and we're going to be in a closed space. So I just leave that honest conversation and say what I know and what I don't. And I tell them we will keep learning and I will keep informing you. And I also tell them that there are more traditional vaccines on the horizon, if that really is something, because I want to leave that door open for them, that there's no point drawing lines in the sand. There is other ones coming. I'll let you know when that one is available.
Okay.
If I can clarify and follow up. So a lot of people ask about long-term studies, right? Like, do we have, a study that's going on for years and years on end and with all that data? One thing to remember with COVID-19 is that even though the time frame is short, let's say 1 year, we've been able to vaccinate billions of people across the globe. And so that data, if you were doing another study on another vaccine, it would take many years to be able to vaccinate that many people. So the long-term data in other vaccine studies is also related to how many people can you vaccinate to detect these small, rare side effects and significant side effects, but rare, right? And so in our case, we have the luxury of having able to deploy all these vaccines across the world, billions of doses, and be able to follow. No vaccine, I think, in history has ever been scrutinized so closely. And so the post-marketing surveillance is key. And it's, we've shown that it's worked because these signals of these, thrombotic events, myocarditis, pericarditis were detected fairly soon after. And then reported. But again, these events happen, these side effects occur very shortly after the vaccine dose is administered. But absolutely, we do need to acknowledge that, like anything, there's unknowns, and it's always very hard to confirm a negative, to speak in completeness or complete there's 0% risk. There's never a 0% risk. So there is definitely room for unknowns. So anyways, I hope that clarifies it.
Thank you very much. Again, I'd like to thank you both because all good things must eventually come to an end, as will this webinar. So there are NACI publications and updates to the Canadian Immunization Guide, and they're found here. And I would just like to let people know there's more FAC webinars and videos on the on COVID-19 vaccines, and you can visit here. And this webinar will be up that people can follow. And again, thank you very much, and have a good day.